Welcome to Dinosaur Brains, episode number 4 for May 1st, 2019. Got the gang all assembled. Paige Riggs, Pat Miller, Fidel
Hey,
Miranda, and we have a special guest tonight. We finally drug somebody on here. So for our two viewers, it's a very special night.
two
But
viewers.
yeah, well, I've been trying to get y'all to get your mom to watch or something. We could have four, but we have tonight with us Andrew Kern. And Andy is what I call him. Andy, he's been with the county for 19 years. He works in the EMD QIU department, Emergency Medical Dispatch Quality Improvement Unit. Andy is a licensed paramedic for the state of Georgia, is an instructor in ACLS, PALS, and BLS. So, welcome, Andy.
Thank you. Appreciate you having me.
Start off a little bit by just kind of telling us a little bit about yourself.
Well, I mean, you pretty much summed it up. So, yeah, so I'd started off, like the rest of the old timers there, just starting off DeKalb paramedics and kind of transitioned into the fire department. Went through that, drug some hose and
Yeah.
rode an ambulance and just kind of enjoyed it while it lasted for about 16 years. And then I decided to take the position as the EMD QIU, which was an opportunity for me to kind of explore something a little bit different. It was dealing with the 911 dispatch center, so it was unique and something that I had never really looked into.
Right.
So I decided to take that position and went to become an EMD because I hadn't been a dispatcher ever in my career. So took a class down at Grady, actually, with an instructor, Susie Marsan, who's works down at Grady, very good at what she does. And so she gave me my initial EMD, Emergency Medical Dispatch course, which seemed kind of foreign to me. It was about clear as mud when I first took it, but that's just normal. And then
Sure.
eventually, got more into it, and then flew out to Salt Lake City, Utah to get my instructor, which was a week-long EMD instructor course, and been to some conferences and got educated, and so here I am.
Wow.
I've been doing it, working on 4 years now with the EMD department.
That's awesome. Really is. So, tell us what a typical day is like for you.
Well, there's a few things that are typical, and there's a few things that are not so typical. So,
Okay.
We have to listen to and critique a certain percentage of calls. It's based on the call volume of the center. So everybody's, if you only take, a handful of calls, then it would depend on the number of calls. So like if your center was fairly small and only took a few hundred calls a day, then you would have to do a larger percentage of the total calls. But
Right.
our center at DeKalb, we process police, fire, and EMS calls, and many people don't realize, but they process over 1 million calls in that 911 center.
Wow.
So,
Wow.
and of course, we only talking with the medical portion of it. We're about 70,000 calls that are EMD'd in that 911 center.
Wow.
So we do 3% of the calls we have to listen to, and we grade them, and they get graded, and then they have a performance standard that they have to meet, and they're educated, so they get a printout for every call that they're reviewed, and they get remediated on anything that needs to be worked on for the call. So we have a certain percentage, but we basically manage the entire EMD program. So anything from initial certification, recertification, continuing education training, evaluating the calls, anything to do with EMD, we do it for them.
So Andy, are those calls, are they random? Are they random calls?
Yeah, so we do, in order to meet our accreditation, not all centers are accredited. And we were the 51st center in the nation to be accredited. The first in Georgia was back in about 96 or so when we got accredited. So my son's here. Of you. All right. So yeah, we're first in Georgia to be accredited. But in order to meet our accreditation, we have to do random poll calls, do 3% random polls, and then we do specialized calls like cardiac arrest, choking, or investigating certain calls. So we will do specialized cases as well, but we keep those separate because we have to do it has to be a random poll in order to be accredited by the agency, by the academy.
What are some of the when you're EMD in the when you pull the call for EMD? What are some of the goals or some of the things that the emergency medical dispatcher is trying to meet? Some of the categories.
Well, they the call taking process is starts off in case entry. So in case entry, they have to get the address, the phone number. They have to verify the address and phone number correctly. It's very scripted. There's very little, basically, I wouldn't say no leeway, but very little leeway on how they take the call. Everything is scripted, from the questions, the way the questions are asked, the order that the questions are asked. Everything is very scripted. So it starts off as case entry. Even the way they ask for the address, what's the address of your emergency? What's the phone number you're calling from? Tell me exactly what happened. They're not even allowed to say, what's going on there, or, what happened is technically not correct. It's okay. Tell me exactly what happened. So it's very scripted, but you'll start off in case entry. Then they'll go, once they complete case entry, they will pick a protocol to use based on the chief complaint. And then they go to that protocol, and then each chief complaint has a different set of key questions that are asked and is specific to that chief complaint. So, for example, if the caller is complaining of a fall, they'll go through case entry, which is the same on every case. Address, phone number, they'll get the complaint, they'll get the age of the patient, they'll confirm awake status and breathing status. Then they'll go to the fall protocol, and the fall protocol, the key questions in the fall protocol will be very specific to that chief complaint of a fall. So they'll want to know, when did the fall happen? How far did they fall? What caused the fall? So that's just one example. So, every complaint that they have, chief complaint protocol they have, has different key questions to address that specific complaint. Once the key questions are done, the code will be updated with the information that's revealed in those key questions. And then they'll go to dispatch life support instructions, where they will give instructions on either basic, just put away the pets, gather the medications, unlock the door, have somebody flag down the paramedics, call us back if anything changes. They may disconnect, or it may go into more extensive instructions where they'll be starting CPR, or they'll be managing airway, or preparing for delivery of a baby, or, so that it can go in whichever direction it needs to go. And so that's basically the layout, case entry, key questions, and then the dispatch life support instructions, and then they'll disconnect the call.
All right.
Sorry, Pat, did I cut you off? I didn't mean to.
No, Mike, go ahead.
Is there a ranking system, as far as percentages of successful calls that they compare nationally?
Yeah. So in order to be accredited, we have to meet certain standards, and it's like a 20-point grading system that we apply for. But one of those requirements is that our performance exceeds a certain minimum standard. So when they're graded on a call, they're either considered highly compliant, which means they have no errors, everything's perfect, and then they can be compliant, which is a combination of maybe some minor errors, and then they can be partially compliant. Low compliance would be the next one down, and then the non-compliant would be the bottom of the road there for them. So they have to maintain compliance a majority of the time. So they can be, I'm trying to remember the percentages offhand, but I think it's 10% partial compliant. I think it's 7-10. So they can be, they have to be less than 7% of their total calls partial compliant, less than 7%, low compliance, and less than 10% of the non-compliant. So we have to be less than that as an agency as a whole to maintain that standard.
Does the agency ever conduct on-site evaluations?
So in order for us to be
Academy, I'm sorry, not agency, academy.
Right. So in order for us to be accredited, we have to submit a certain amount of our calls that we review to the academy, and then they review us reviewing the operators.
Oh, wow.
And then we get graded, and we have to meet our standards. And some of it is, as much as a lot of it is black and white, pretty, it's either right or wrong. There are some areas that are gray, believe it or not. It's hard to kind of figure out, exactly how that would fall into the standards. So there are a few slightly gray areas, but for the most part, it's pretty well scripted out. As they either did it right or wrong, or they didn't do it at all. But yeah, we are graded as part of our accreditation, and there are some agencies out there that buy the system and loosely use the system. They'll have it. They'll use it occasionally when they want to, or they'll be on the old flip chart system. They don't have the updated software, and they're not accredited, and they don't really meet any standards. And there's some agencies that don't use it to the full extent that they need to use it, or they could use it. But if you're an accredited agency like we are, you're fully on board. You've got to meet all those standards.
Does that put, let's say, an agency that's riding the fence like that? They're half in, half out. Does that put them in any type of, I don't know, maybe a higher rate of legal consequences if they, mess up a call, or how do they deal with that?
So it does. Basically, by us using the Academy's protocols, is we have an international standard that we are following. So I kind of compare it to, ACLS, for example. If you're a paramedic and you go out and you run a cardiac arrest and you follow all the standards that are set by the American Heart Association, and you do everything you're supposed to do, it's hard for anybody to come back at you and say that you did something wrong, because you can point to these international standards and say, no, that's just the way that, it is. And I did exactly what I was supposed to do. So it's very similar in those regards. If they follow the protocol and they do what they're supposed to do, then it would be difficult for anybody to come back and say that they didn't do their job. And how the other agencies get around that is that they have to have a pretty strong policy, or a set of policies in place to address all those issues that are gaps. So in DeKalb, we have that option too. If we don't agree with something on the protocol, we can actually write a policy and put it in our policy book and follow that policy. But it cannot. It can only add to the protocol. It can't be less than. We can't go below the standards with that. So there are some limitations to that. But it protects the operators first and foremost, because freelancing is a problem. We've had operators in the past when a lady called because she was having difficulty breathing, and the operator told the lady to go put her head in the freezer. That was a freelance instruction.
Was
Uh,
it Pat?
and the reason-
Were you working at 911, Pat?
At least it wasn't the oven with the gas on.
True.
Yeah.
Yeah.
So,
Yeah.
She said at least it wasn't the
Oh.
oven with the gas on.
Yeah.
we won't get into all that. Yeah. So yeah, but the reason why she did it was because she had asthma, and
Yeah.
when her asthma flared up, it always made her feel better. So as a whole, we can't have
Oh,
operators telling callers to go put their head in the freezer. And if something were to happen to the patient, who's going to be responsible for that instruction? DeKalb County is going to wash their hands of it because she's not following their protocols or following their guidelines. And so she puts herself at increased liability by freelancing.
Right.
So
And,
there's no
that's why
freelance.
they're scripted as they are, correct?
Yeah, they're very scripted. There are some exceptions, but even the exceptions are very limited. Like, there are plenty of questions that are asked that even the clarification to the question is scripted. So you may ask a question, for example, the question is the caller completely alert, is the way that the question is asked. If the caller doesn't understand, well, what do you mean by that? Are they responding to you appropriately? Is the clarifier is written on there as a clarifier. So not only is the question scripted, the clarifier can be scripted. And in cases where the clarifiers aren't scripted, then they cannot materially change the question. So they can use a clarifier, but it's very specific rules with that. So yeah, very scripted. The order has to be filed exactly as written, exactly in the order as written. Not a lot of leeway on their end.
I feel like I'm hogging the floor.
Andy,
I think it's awesome what Andy does. I could sit here and just talk to him all night, but go ahead. I didn't mean to interrupt, Pat. Go ahead.
no problem. I was just gonna say, like I think the percentage of bystander CPR in the country it averages like 33%, somewhere in the low 30s. And the CARES data came out for last year, and DeKalb County is actually at a 51% bystander CPR rate. And I was going to say that has a lot to do with our EMD. It has to. So
yeah,
congratulations, Andy. That's pretty amazing.
No, I didn't even know that, and that's kind of information I need, because I like taking that to the operators and giving them accolades for doing that. But when I first got into the position and I started listening to calls, we would listen to every cardiac arrest that comes in. We would do that as a specialty case, and it truly amazed me how many people are not doing CPR until they're told to do CPR. It really does.
Yeah.
Like I never would have thought that. I mean, as much education has been put out for bystander CPR with the American Heart. I mean, for all of us in the industry, it's just common knowledge, but it's amazing. People first instinct call 911, and I would say, not officially, but I would say, just guessing, I would say probably 80% of the people who call 911 that need CPR are not doing CPR until they're told to do CPR.
Wow.
How about that?
So,
yeah.
And that, it's aggressive. The protocol really is impressive in the amount of time it can start CPR. The address and phone number takes a little bit of time, and that's always a priority. In case they get disconnected, you got to have an address and phone number. Then you get the complaint.
Sure.
And if you say, okay, tell me exactly what happened. Oh, I think my husband's not breathing. Send the ambulance. There's a fast track pathway that they can click on, and within just a few seconds of getting the complaint, they can roll right into giving CPR instructions very quickly.
Oh, that's great. That's good.
That was going to be one of my questions too, Andy, was Do we find that since it is so scripted and there's so many things that have to be handled, does that actually delay hands-on to CPR? Meaning when you're trying to check responsiveness of the patient, if they don't respond exactly right, does the dispatcher have to keep jumping through hoops until they say the exact thing that they're looking for?
So the academy that oversees the EMD, International Academy of Emergency Dispatchers, is who oversees and kind of writes the scripts for them. They work very closely with the American Heart Association, and they both agree that rapid CPR is needed. So the rules are, if they're not awake and if the breathing is unknown or uncertain, that they will go ahead and start CPR. And another thing that they added, that fast pathway that they added, they don't even need to ask a wake and breathing question anymore. If the caller makes it obvious that the patient is not awake and not breathing, if the caller calls up and says, "Oh, I think my husband, I don't think he's breathing," it allows them to go directly into start CPR. So it's very aggressive in those. There's also a built-in safety with that. So what it'll do is it'll go through the protocols and it'll ask, are they awake? And they may say, no, they're not awake. And then it'll ask if they're breathing. And, with agonal breathing,
Right.
there's some confusion with untrained callers. They may say, yeah, he's breathing. So it'll go into an unconscious card because somebody who's not awake but breathing is unconscious. So it'll go into an unconscious card.
Right.
But when it goes into the unconscious card, the first question it asks is his breathing completely normal? And if they say no, it's not completely normal, then it'll force them to go into a breathing detector tool where they say now every single time they take a breath in, say now. And that does, a little bit of a delay, but it will time the respirations and it will catch an agonal breathing type case and it will start CPR at that time. So there may be a little bit of a delay, but if it were in that circumstance were to happen, it catches those type of cardiac arrest. It does the same thing with seizures, because seizures, as a general rule, all seizure calls are handled on the seizure protocol, not on the cardiac arrest, because it's quite common to not be awake and not be breathing effectively while having a seizure. So as a general rule, all seizures are handled on seizure call. But once the seizure stops, they're forced to do a breathing detector tool or use the breathing detector tool to evaluate the patient's breathing after the seizure stops. And if it's not adequate at that time, they'll start CPR, and that catches those VFib seizure type activities that they see. So, there can be circumstances where it could be delayed, but it's an understandable delay because of there's going to be cases where people just pass out and they don't all need CPR. There's going to be cases where people have seizures and they don't need CPR. So. It does a pretty good job. I would say as a whole, I've been pretty pleased with how it kind of protects itself under those circumstances.
So have the call takers have they had any saves over the phone?
That's what I wanted to know too.
Yeah. So we follow up with the cases, and it's sometimes hard because we don't know the outcome just by listening. But if there's an indication that the person starts breathing on their own, or we've had some choking saves recently.
Wow.
So yeah, choking, airway save, cardiac arrest save. We actually reward them. They get a certificate, they get a pin, kind of something, just kind of get some recognition for their accomplishments. So yeah, we try to follow up with them. We will pull a PCR, request a PCR to try to get more information so that we can get them their.
That's excellent.
If they get a save.
That's excellent.
Yeah, and even like basic like airway save, like people don't. for us, it's just kind of secondhand nature. You walk in, and somebody's needs their airway open, you open up their airway. But for them, I mean, they have to, for them to identify that the person is unconscious, and they will actually give airway instructions for every unconscious person that is adequately breathing. So if they're not adequately breathing, obviously they would be starting CPR. But for somebody who is unconscious and breathing adequately, they will still give instructions to lay them flat, open up the airway. So, we've had patients that were, having noisy respirations, some snoring respirations, and they opened up the airway and the airway cleared up. And, even that could be considered an airway save as well. They'll get a little accolade for that. So, yeah, a lot of
great,
in-depth type of treatment that a lot of people don't fully understand until they look at it. Pregnancy is another one of those.
Oh, yeah.
It blows my mind the amount of instructions that they'll give to a pregnancy case.
I heard that video that you played when we had the class. That was pretty neat, actually.
Yeah.
Kind of changed how I kind of looked
Yeah.
at the dispatch center a little bit.
Yeah.
I've had my time in the county where, I got sent up to dispatch, but listening to that tape, yeah. But listening to that dispatcher work on that tape, that's what really kind of changed me. I really did. I was like, well, their job is pretty hard.
Yeah.
They do have they really do have a tough job.
Yeah. And be honest with you, I tell them all the time, I could not do that job. I mean, some people could,
true.
but I'm not a multitasker. Yeah. If I got a text message right now, I'd have to totally like close y'all off and read my text message, and then I'd come back, and then we can I'm like a one-minded type person, and they've got like 5 or 6 things going on at one time. So they're multitasking, they're keeping up with it, and some of these calls and just dealing with the public, as everybody knows that deals with the public, and you hang up, they're right back in your ear again.
Yeah.
They work off of the switchboard up there. They don't get to. They can opt out of the system. They had to get out, but if they're live and ready for a call, as soon as they're open, it picks up in their ear, and they don't have a choice.
Oh, wow.
It just picks up for them.
I did not know that.
Yeah.
So they could just be sitting there. Next thing you know, somebody's in their ear.
Yeah. So they're, once they're in the queue, as far as, available for calls, it just works on a switch. So they're just sitting there with their headset on, and all of a sudden the phone system will pick up automatically. And what a lot of people don't know, with our new CAD system, it actually, the beginning message is automated. So it'll pick up the phone, and then in their own voice, it'll say, DeKalb County 911, what's the address of your emergency? They don't even have to say that. That's just built into the system.
Oh, that's so neat.
Yeah.
Oh,
and the person will either listen and give the address, or they'll just start talking about how they, what their complaint is. And then the operator has to redirect them and, make sure to get the address and so forth. So yeah, that's a pretty neat feature that they have on the CAD.
Andy, I was just going to ask, now I knew, we always had position 48, that did our system status management. And then when AMR became our ambulance contract provider, they had a person there in dispatch that did system status management. And I heard they don't have that anymore. What do they do now? I mean, for like moving ambulances around, what do they do?
Yeah. So, from what I know, and this is kind of just being around it, because it's not, my direct area, but from what I know, there is still a 610 position up there, which is AMR position. So when we gave up the 48, or we stopped providing 48, that was taken over by AMR system status management 610 position. And they used to do more up there. They used to help out the dispatcher or the operators with, what units to send to what calls, and they seem to be more involved, and they have got less involved. And actually, I just talked to an operator today. I was kind of remediating, doing some training with an operator, and she was telling me how she used to like working fire radio, and now she doesn't like working fire radio because 6-10 position, they don't do anything. I mean, they're in they look at their Logis system, which is a mapper system that they're trying to get away from and trying to go to our CAD system. But see, Logis is not just a map system. It's all built into the way they get paid for the call, their time, for personnel, they use it for personnel paying and, whatever hours and everything else. So it's not as easy just to get rid of. It's not just a mapper. So they're kind of working towards how to improve that. So I know that there has been some interest on everybody's end, the 911 center as well as the fire department. There has been some talks about bringing a 48 position back. We're taking volunteers if yeah. But
Thanks.
I can nominate all of y'all if you want me to. I don't mind.
No, that's okay.
No, you'll know that I did something really bad when I'm the 48. But what they actually did, oddly enough, how the county works, they actually eliminated the position when they did away with 48. So now it's kind of a big HR nightmare,
I bet.
Back,
I bet
which I'm sure they could, if they're really motivated to. But it's not a vacant position anymore. But I think the goal is to bring it back, and they want it up there. Somebody to help them out.
When I worked in private EMS, I know that I did some time in the dispatch center, and we had the computer aided dispatch that would identify the closest unit. But even with that, it's a big chess game. Dispatching calls and posting units, following a system status management plan. Fidel's very familiar with it too. Constantly moving people around and stuff. It's extremely challenging, and knowing that they are up there and they're limited without a perfect solution for a system status manager, that just adds to their stress. I'm sure it does.
Yeah, and a lot of that, this new CAD is pretty amazing stuff, really. The CAD we have in the mapping system and the programs that are built into it really do a good job. And we've had some complaints from the field. And again, this is not, directly my area, but just working around them. Some of the complaints that have come in are investigated, and just about every time it comes out to be the system is correct. And so there's always going to, what we used to identify as a station's immediate territory and response area. The system doesn't look at it that way. The systems are going to look at the response areas based on the actual geolocation of the unit themselves, and it's going to build that. And they actually have a software program built into the CAD that they paid extra for that does move ups and posting.
Oh, that's nice.
Yeah, so all that is really animated, and it could go to new levels. And one thing that has been some interest in recent time is just incorporating all these systems together to be able to kind of manage itself. They may even have the system may actually dispatch units initially with like a robotic voice with very little or no delay in the dispatch at all.
It'd be like Paige Riggs' voice, though, but like a robot version of that.
Yeah,
absolutely.
Because nothing gets you up at 3 a.m. to go run a call.
Like Paige Riggs does.
His voice, yeah.
That's all you need.
No, because I'd be yelling, "Get up! Get up!" We're gonna implement that next week.
I know. That's awesome, man.
Yeah.
That's gonna be great. Thank you. So Andy, we'll just tell everybody that's your idea about Paige and her voiceover.
Yeah.
Yeah.
That was awesome, Andy.
Hey,
Solving problems.
it sounds like a good idea to me. As long as it's not my voice. Putting people to sleep.
Me too. Yeah, me too.
Yeah. So yeah, it's exciting. I mean, there's the CAD initially had,
It is.
ping. It has features that if you don't know where you are, it can send a text message to your phone, and then when you reply back to it, it actually ping your location back to the CAD, and so it's fully functional. There's actually text to 911 software built into it, which is something that's kind of gaining popularity nationwide. So if we ever, which would be a nightmare, but if it ever came about that we're going to be doing text messages to the 911 center, that CAD can handle it. So it's a modern CAD, very expensive CAD, and
It sounds like we're just learning the tools of it too. Sounds like we're just, we hadn't even touched the capabilities too much yet. Sounds like we're just kind of figuring it out.
yeah, definitely. There's a lot of people that kind of that's their area, that's their specialty. So I can't all that, but yeah.
No, yeah. But it sounds awesome though to me.
Yeah, and
so speaking. I'm sorry. So speaking of a modern CAD, are your personnel in the CAD set up for a huge disaster, like an earthquake or flooding or something that's out of the norm? And can you elaborate on that?
Well, there's certain limitations to the center. The limitation is not going to fall on the CAD. The CAD will handle as many calls as you can push into it. But the limitation in any situation like that is always the ability to get calls into the center or getting overwhelmed with calls. So, if you put, 100 operators up there and they all had a phone set, that CAD would input as many calls as you possibly put into it. It doesn't, I don't know what the limits are, but each individual station, regardless of how many stations they got, would push calls through. So, but the limitation is really in a natural disaster or any type of situation like that is going to be the amount of call takers that we have to receive the calls and the amount of dispatchers that we have to get out the calls. So, you can store, 100 calls in CAD, but if you can't get them out to the units, then they're just sitting in CAD,
Right.
waiting. And the same with coming in calls. I mean, the CAD can only process so many calls, and then you're going to get a recording that says, please up because, your call is important to us and you'll be the next in line, and they're just going to be stuck in the loop. And what a lot of people don't know either is that AT&T, which manages our phone lines for the county, they have an overflow 911 center.
Oh, wow.
It doesn't happen very often, but what would happen and it's not to overflow our lack of call takers, it's to overflow the phone system's ability to bring calls in. So have you ever, it's rare, but have you ever tried to use your cell phone and it says all systems or all networks are busy?
Right. Yeah.
That's the phone service backup. That's too many people hitting off of a tower. And so if that were to happen, and it's a 911 call, AT&T actually operates a 911 center that will actually pick up those calls.
Wow.
And they will never come into our 911 center because it doesn't reach us ever. It goes directly to, so it's like it's AT&T's catch-all in case their system gets backed up. And that would happen. That rarely happens in everyday life, but it would happen in those extraordinary circumstances where you had a tornado and everybody's calling everybody to see if they're all right, and everybody's calling 911. The towers are going to get overwhelmed, and then AT&T is going to get some 911 calls from that. And so, yeah, that's where the limitations when it comes to those type of systems are. the CAD is not going to care one way or the other. It's going to be, it's going to perform. But yeah, the limitations are going to be on the other end of it.
That was a good question. That was awesome. So where do you see us in 10 years from now? I've been in EMD, and I was reading today that they're talking about stroke care with emergency medical dispatch, identifying a stroke patient before EMS even gets there. And
right. So they have that, we're doing that. So,
okay.
The system can accurately evaluate, and the operators do. It's paying the butt for them, to be honest with you. But they actually go through a version of the Cincinnati stroke assessment with them and have them answer the questions, and they will give them a rating of either confirmed stroke, partial, possible stroke. And, there's a certain ranking. I think it's like clear evidence of stroke or, possible stroke, whatever the ranking is. So they'll give them a ranking based on the little stroke assessment they do. And then the system has the ability, or we have the ability, I should say, to call a stroke center and put them on a pre-alert.
Wow.
Just based on those findings. And it's been proven to be very accurate. It's the same test that the paramedics do in the field.
Yeah. That's what I was reading about. They said it's actually, I think they've seen a 27% improvement in stroke care in one study that I read.
Right.
That's awesome.
Right.
Pretty
So
significant.
that's great. And that works well. The limitations that we have to it is that the 911, the call takers, they can do a stroke test. They can get with pretty good confidence that the person is having a stroke. So they could call a hospital and put them on stroke alert and get a neurologist en route and get all the, the people called in that need to man the center for the stroke. But the problem is we transport to so many different hospitals that it doesn't really make sense for us. We don't know where they're going to go. And so we don't use those capabilities to the full extent, but my understanding is Grady does use that. And of course, their advantage is that they're, Grady and that they have the hospital there. Not to say that they have to go to Grady, but they can put Grady on alert, and Grady's a level 1 trauma center, so they have all the people there anyways. Yeah. But they can utilize that system a little bit better than our system, where you use, a number of hospitals in the area. But yeah, the capabilities of it is impressive.
It is.
And as far as the other question about, 10 years down the road, one thing that we're looking at heavily, and it's one of the best things that we've got going, but it's still in the very early stages, so don't get everybody excited about it too early. But we are probably several years out, but they do have a nurse line built into this same type protocol system, and this nursing line, we can actually take out pretty much all the alpha calls and a lot of the Bravo calls, and we can actually refer them to a nurse that works in the center, and the nurse has a separate set of protocols that they can go through a series of questions and triage. And then as part of that system, that system is great, but the system is nothing without the supportive care you have to have with it. So as part of that system, you would contract with urgent care clinics, you would contract with dentist office, you would have Uber transportation arranged. There's billing that can be done through insurance through it. There's grants that can be done.
Man, that's awesome.
So the potential is that we pull out some of these unnecessary calls. People call obviously for everything. So, if you call because you have a toothache, if they're willing to talk to the nurse, they talk to the nurse. The nurse says, well, we can get you an Uber out there to pick you up, and we've got a dentist that will see you, and that's kind of the idea. So the supportive mechanism that needs to be involved in all that has to be in place. It's a huge undertaking, and there's a lot involved in it. But that is something that we're aggressively looking at, and we've got actually some interest from the CEO's office and commissioners regarding kind of implementing something like that. So that's the future.
That's fantastic.
Oh, it does, man.
We're
The future sounds really good.
Yeah, yeah. And,
I mean, it really does. And who would have thought, though? Who would have thought that in that setting, that the dispatch center could make such a difference, in the survivability of a patient?
Yeah.
I never would have guessed it,
Yeah.
And look at it.
It really all starts there. And, the old way of thinking, not very long ago, but the old way of thinking was, we would just want to send these calls out, get the units rolling.
Right.
Even best case scenario, and we do a kind of a scenario with our operators when we do training, and we kind of go through the whole process. How long do you think it normally takes for the caller to actually call 911 once an emergency happens, and then how long does it take for the 911 operator to pick up the phone and to process the calls? And all of them are relatively quick. You got 30 seconds here and maybe a minute here and another minute there, and by the time the unit's sent out, even best case scenario, and you got a 6-minute response time. Okay, how long does it take for the responders to get out of their truck and get all their equipment? And okay, what's the time to apply the pads? And the study was based on time of the emergency to time of defibrillation. And you really can't get those times really less. 6 minutes would be an amazing time for that. But, you're looking at at least 10, 12 plus minutes for time of defibrillation. You don't have a patient after 6, 8 minutes.
That's right.
So it's kind of like, what role does the 911 center play in all of this? They play a key role. Now, we don't have a patient. There's no patient to go to if they're not providing the care. So, yeah, it really is an eye-opener to see and how they're evolving that in the way that we as the fire rescue can get the most out of our system. It all kind of revolves around the 911 center and getting the most out of what we have. We don't have unlimited resources, obviously. So, when do we send an engine? When do we send an ambulance by themselves? When do we send a paramedic unit, emergency or non-emergency? All those factors are kind of built into the coding system of this program. So, yeah, tremendous. The system has really kind of changed the dynamics, I guess, of what we can do.
I'm proud to be a part of that.
Yeah, I had.
Go ahead.
Yeah, I had heard that that we have EMD. I heard there was an FMD program as well that we might be looking at. It's they get that call for apartment fire, and then the comments say outlet sparking, and everybody goes but still we have a full response. There are 2 truck companies rolling, 3 engines. So the FMD would basically, say outlet sparking, we're going to send 1 engine. Is there any truth to that, or what do you know about that?
Yeah. So we have buy-in from Chief Fulham, and he wants the EFD, they call it, Emergency Fire Dispatch. They call. So it is in the budget. The rumor's been going around. They've been talking about it for years. I think we're actually getting pretty close to it. It is a little bit of a financial hit. It's a significant amount that they charge for us to purchase the program, and then there's software, and there's training all involved in that. But
it's a lot.
EFD is projected to come on board, and the police chief, even though he just retired, but the police side also showed interest. But they're going to be the hardest ones to get over. Police is just a whole different animal altogether. I mean, police, when we look at system status management on the fire or the medical side, if we've got 1 or 2 calls holding, that's a problem. Police, any given day you go out there, they'll have 20 plus calls holding.
Wow.
I mean,
Wow.
it's just a monster. And how their system status management is done by sergeants. They'll hold units, and so that's one of the big complaints that I used to get a lot was why every time I ask for PD they ask me what I need PD for. And that was the big complaint. If I ask for PD, just send PD.
Right.
Why are they asking me? Well, the reason why they're asking is because they got 40 calls holding. They got an armed robbery going on.
Right.
And as much as we would like to think that fire only calls PD when it's an emergency and they need them, well, that's not the case. And they need to know how to prioritize the call. If you're getting your, whooped on scene, then they're going to step it up and they're going to put you in the top of the line. So many people just, they just don't understand the system as a whole. I mean, the PD's a monster when it comes. A large majority of the calls we get are PD calls.
Andy, let's backtrack a little bit.
Yeah.
And let's go back to the nurse line. Can we go back to that for a second?
Yeah.
Do you know of any services that utilize that?
There are a handful, but we would honestly be really one of on the forefront of that. I mean, there's a handful. I think Las Vegas is doing it. I think Salt Lake City did it, but it kind of failed a little bit there. They didn't have the support systems in place to make it work. There was another place because I talked to a few people.
Los Angeles.
Is Los Angeles doing it?
I can't remember. They've done a bunch of nursing stuff.
Yeah, they may be doing their own. There are people who are doing their own nursing thing too.
Grady.
Actually, Grady does something similar, but they don't use the actual the system. But they and Rockdale, believe it or not, I think Rockdale
Really
has a PA.
Oh.
Has a PA unit. But the problem with that is, from what I hear, it's not been very effective because you have to have a PA in place that doesn't mind pulling calls out. It's going to take care of business, going to write prescriptions, going to follow up. And if you get a PA that's scared and doesn't understand pre-hospital medicine, they're just going to call an ambulance every time something happens. And that's what's happening with their system is that their PA is not pulling out as many calls as they had anticipated, or from what I hear. So there are other programs, but this particular program, there's only a handful of people using it. So we would be kind of a good, test for that.
I just thought they'd be great to have on here.
Yeah, I think it'd be great. It's going to be a monster to try to figure out, and it's going to have its limitations. I mean, when you have one nurse up there, that one nurse can only process so many calls.
Right.
So when you have as many calls as we have, maybe they can pull out 15, 20 calls a day. I don't know, maybe more. I mean, that does add up because that's 15, 20 calls that somebody's not running, but it has its limitations, and it's not, you're not going to force somebody to not have an ambulance. You're not going to tell them, oh, you have to talk to the nurse. We're not giving you an ambulance. That the system's not going to do that. So the system's going to offer the nurse line. The nurse can take it, process the call. So it's kind of still volunteer type basis for the caller to do that.
Yeah.
So,
Andy, sorry about this question. This was a question that I always, I hear people saying, out in the field, they'd say, "Why does an engine go to a doctor's office?" What's your thoughts on that? I know it makes sense if it's a cardiac arrest at a doctor's office. Well, yeah, obviously you got to go, but I'd hear a lot of people say, why are we going to a doctor's office on the engine? You got a doctor there, and the person's, sick. Why are we going? So,
yeah,
I don't know. I don't know the answer to that.
Yeah, that's kind of opening up a whole big old can of worms there. But
Wait, you have to answer that, Vince.
yeah, I try to explain it.
Sorry, I didn't mean to put you on the spot.
No, you're good. No, it's a good question, actually. Very good question. Because
And why can't you do something about it?
yeah. Well, anyways, I got to go.
Yeah.
Yeah, unfortunately, we're kind of limited. But
Yeah.
so the reason what we've got going on, the protocol has a 33 protocol, which is interfacility transfer protocol, and that
Okay.
protocol can be used for any complaint at a medical facility. And the reason why we use that protocol for the 911 operators is because a nurse is assumed to know what to do for the patient. So, like I said before, the protocol is very scripted. They have to follow the script exactly as written. So if they use the 33 protocol for the interfacility transfers, it allows them to get a handful of questions asked, and then it allows them to basically get off the phone because the nurse is taking care of the patient. And so using the 33 protocol has been encouraged because we don't want them to have to tell a nurse, how to treat a patient.
Right.
Because then the nurse gets offended.
Right, that makes sense.
And yeah, and so that was the idea. And then
Right.
the old administration, the thought process back in the Foster days, let's say, the old thought process was if a nurse or a doctor is calling 911, then it must be an emergency. Well, obviously,
Oh, yeah.
Yeah.
that's not necessarily true. It's probably further from the truth. But
Right.
the premise was if a trained medical professional is calling for an emergency ambulance, therefore it must be an emergency. And so there was never any leeway put into the 33 interfacility transfer protocol to do anything but send an emergency response and an engine and an ambulance because it was assumed to be an emergency. And so recently we've re-looked at that, and with the new administration and Chief Dobson has been great, real open-minded with how the system should work. And so we have a few options when it comes to medical facilities calling 911. And the two options are you keep protocol 33, but we have acuity levels built into the protocol that we can actually assign acuity levels into the protocol system, which personally I like that idea because it gives the operator a little bit of leeway. If the nurse says I only need an ambulance, don't send an engine, they can actually select that. And then the other option, the other option is to do away with the 33 protocol altogether and just go strictly on the chief complaint of the call. But the problem with that is you're going to run into the same problem. It may be packaged differently. It may not say interfacility transfer at the top of the dispatch of the computer, but it'll say, chest pain or whatever their complaint is, and the engines will still be going on the call. Because if they answer those questions, all those key questions that they ask, if the nurse if they've got chest pain and they're over a certain age and they've got whatever symptom, it's still going to code it at a higher priority. So the system doesn't allow change in the priority of the call just because there's medical personnel there. You know what I mean?
Yeah.
And then
that's a good thing because, somebody's having a STEMI at a doctor's office. You might need a rider. The ambulance might need a rider, to ride in with them to the hospital. Somebody could be at a doctor's office and be in VTAC.
Yeah, exactly.
And they need the cab fire rescue there. So, absolutely.
And we've brought that up, because I've made the argument to our administration. I said, well, if a trained doctor is on scene and they say that they only want a non-emergency ambulance, then they should be able to pick what they want. They're the trained professionals. They're with they're there with the patient. But the flip side to that, and the argument to that, is we don't want them telling us how to respond to our units. The patient it is what it is based on our assessment that we're doing through the EMD protocol, the questions are asked the same as always, and they're given an answer to. And just because a nurse may not think it's a priority, if our protocol says it's a priority, then we're going to send a priority response. So that's the other end of the argument, So it's not,
Mm-hmm.
you know what I'm saying? Like when you start looking into all these cases, it happens a lot with, my world is once you start looking into all that, what seems like a pretty black and white type situation starts becoming more gray the more you kind of dive into it. And that's just another example. It's like, it's at a doctor's office. Why are we sending an engine? Well, it may seem simple. And then when you start looking at all the ins and outs and you get in rooms and, people are having to put their signatures on the dotted line when it comes to these decisions, it's not always black and white. There's a lot of more different type of thought that goes into it.
Sure. Yeah, that makes sense. Thanks for answering that.
Yeah. I probably, I just, I don't usually clear things up, but I just add more confusion. So,
No, that was good.
No,
Good answer.
That made a lot of sense.
It really did.
It makes some sense.
Yeah, it can get pretty, pretty messy, I guess, when you start thinking about all these ins and outs and how to work the system. And so.
Well, Andy, thank you for joining us tonight. I've learned a lot, and I've enjoyed having you here. And we'd love to have you back again sometime.
Absolutely. Appreciate you having me.
Glad to have you. Well, Andy, thanks again, man. We'll see you tomorrow.
All right. See you
All right.
Andy, thank you.
Time for our pick of the week. So
I'll go first.
you're going first. Fidel is out of the gate.
My pick of the week is OPQRST sample.
Yeah, I know that probably sounds weird to some of the folks that might be watching us that aren't involved in our daily life. But it's been a week for OPQRST. We teach an EMT class, and Fidel has been teaching patient assessment this week. And OPQRST has been the topic.
It's been the failure.
Yeah.
Fantastic.
Massive failure.
Yes.
Because tomorrow's decap BTLS.
Yeah.
Oh, wow. Yeah.
A little bit of a longer
Fantastic.
acronym. We'll see how that works.
I'm crossing my fingers. They're going to do well on decap BTLS tomorrow.
They got to do something after Monday.
If they study, they will. If they study and memorize that, they will. That whole class is capable of being one of the best classes that we've turned out. But they're going to have to step up, and they're going to have to start doing what they need to do to mark their place in the class history. Every class wants to. Yeah, every class wants to come out of the gate strong. Every class wants to represent themselves well, because after you've been here, Pat's getting ready to retire. I'm 18 years into it. The one thing you have 18 years later is I was in class so-and-so. What you got, Paige?
Yeah.
I see something. What is that?
I have no idea what that is.
It's, I'm afraid to ask. Oh, man. It's probably something that's going to be on the quiz tomorrow.
I promise. I'll be it.
Yep.
See how many of them watch this video.
Okay. We'll see.
There's
We will
probably about
see.
6 of them sitting in classroom 1 right about now.
Yep. Probably so. So I like your pick of the week, Fidel. Pat, do you have a pick of the week?
I do. I'm sorry, this is more of a question. But I wanted to pose it to you guys as instructors and everything. Just a thought. I was thinking about a couple things, and I was thinking about, one thing you hear, we've got EMTBs coming out. We used to train people to be advanced EMTs and all that. And EMTBs can do a lot of life-saving skills. and they should be very proud of that. They can do a lot of the main things that will save a life. And so I was thinking, well, from the field perspective, what is it they can, Instructor Lillard and I were talking. Bill's like, well, an EMTB can do everything an EMTI can do except put in a supraglottic airway and start an IV or an IO. And so I started thinking about, and you guys probably remember this, way back in the day, Fidel, I know you're from Kansas City and everything, but before Georgia recognized the national registry, we had Georgia certified. Okay, Paige. Mike will remember this.
Yep. I was one of those.
And so back in the day, you were Georgia certified EMT, and you had that nice round patch, and it said EMT-A, and the A stood for ambulance.
Yeah.
Well, back then, AED technology was fairly new, and it was just available to public safety, to the fire departments and the EMS. Now you have AEDs, in the mall, but there was this class you could go to. Somebody at the state level, I guess, decided, hey, this is really important life-saving technology. We need to put this in the hands of as many people as we can. And they actually had this class, and I don't know how long the class was. I never went to one. I'm assuming it's probably like an 8-hour class, but you could become certified to use the AED, and you'd be an EMT-D, and the D was defibrillation.
I remember that.
You remember that? You were EMT-D. And so what I was thinking, I don't know what it would take, if this is, I know it'd be something that the state level would have to approve, but they basically take EMTBs and they put them through, 8-hour class. I don't know. They teach them how to start IVs. You guys teach them how to start IVs, maybe teach them how to start IOs. And then that's just that one skill. And I just say that because that's one thing, from the field that you it's kind of the, I don't know what to call it, the elephant in the room maybe, but we got these EMTBs coming out. What can they do? Well, they can do a lot of things. They can't start IVs, we send them in the ambulance, and if the paramedics say, well, hey, can you get a line for me? Well, they can't do that. So the idea is, it's just that one skill, that extra, 8 hours, 16 hours. I don't know what that would take. I don't remember when we were in EMT school, how long did it take us to learn, how to start an IV? It was, so this is just a thought. I'm just throwing that out there to you guys. You guys are the instructors, and that's your expertise. So I don't know. What do you think about that?
No, because with the IV comes more responsibility, more pharmacology, because the EMTI can give that D50. That's a whole nother ballgame. We can give IV fluids. It's more class. The whole purpose of basic is to force them to go to AEMT and learn more advanced assessment skills and pharmacology and things like that. The goal is not to stay at basic. The goal is to go to AEMT school.
Right.
It's just that we have people who are not going to do that.
Right.
Right. Okay, that's fair.
So I'd love for us to go back teaching AEMT school.
Same here. We go back to it.
Yeah, I would love for us to, but it's just not in the cards right now.
I would love to turn out EMTAs, but I want everybody kind of think about it for a second. So it's not, think about all the calls out there that go bad. And it wasn't truly the IV that was going to make it better. It was recognizing that the patient was in a certain level of distress or a certain situation that was missed in their assessment skills. That's what usually led to the patient's demise. The EMTs in this situation, like our EMTs, they can't start IVs, but they replace that with anatomy and physiology. They're taught at a level of what me, Fidel, Pat, and Paige too. We didn't get this level of anatomy and physiology until we got to paramedic school.
I don't even think then we got it.
You were where?
I don't even think then we got it.
We may not have.
Yeah.
But they're getting it.
Impressive.
And so people go, well, what? Well, okay, you give them all this, but they can't do anything with it. And my argument would be, oh, you're so wrong, because you want them to, an IV is just fluids. It doesn't replace anything at the cellular level. But what we do is hopefully turn out an EMT who can recognize that this patient is in a certain level of distress, and they can provide a better patient assessment, identify these patients' needs, and put them on the right track. When I get there, think about allergic reaction. When I get there, I'm not, if I've been led down the road of, let's say, an asthma attack, well, it takes me, and so many minutes to figure out, oh, wait a minute, this is an anaphylactic reaction. This is not an asthma attack. Recognizing what it is right away and nailing it right away, then the appropriate level responder comes in, they get a good report, and I'm immediately going to my drug box, not for an IV, but for sub-Q epi or something like that, or recognizing a patient has an altered mental status with a GCS less than 9. Well, this is a patient that's going to continue to deteriorate if we don't do something, and that something's not an IV. That something's airway control and airway management at the basic level. And so
right.
I get it, and I would like to see, I wish I could turn out this with the ability of them having a couple extra tools. One would be more of an airway management, being able to put in a rescue airway.
Okay.
But that's just me. But if they do what they're trained to do, they could be a huge asset to the crew that they're with, because they're fresh. And they can, they're fresh. They should be able to identify emergencies better than the ones we turned out, better than we could. They should be able to identify certain illnesses and certain sequences. But that's me. I want to turn out the best product that we can at that certification.
Absolutely. Yeah.
What do you think, Paige?
We'll find out after they take this test coming up.
Yeah, I don't know. Me and Paige are wore out.
Yeah.
and we are. Tonight's rough. And, and I know
They're
the
just
students.
life-sucking.
Any of the students are watching, and they're not tired. Look, we are mentally strained, because what they don't see and what we didn't see as students, and maybe our instructors did this or didn't, but me and Paige are constantly meeting, and we're talking about
How
what
they
can
don't
we
know
do different.
OPQRST.
Yeah, how they don't know OPQRST, and how today they didn't know what a general impression meant before.
Man, they were going on a date.
Yeah, I meant looking good in your uniform. God bless y'all, 113. But no, seriously though,
maintain eye contact.
But when we recognize that, me and Paige we are racking our brains to come up with ways to present this material, and Fidel's the same way, to all of us, to present this material. If we're not, and I can present it one way, and Paige comes up, presents it a way, and they get it, and then it flip flops. We trade off that hat, but we're always trying to come up with ways to make it sink in. And not just to make it sink in, and not, we want to keep everybody, but at the same time, please understand this. We want people who are not just going to pass the EMT exam. We want competency. Above all.
Yeah.
And we can look at numbers all day long, and we do. Me and Paige look at numbers. But at the end of the day, we want competency, because we want people in our county to receive the best possible care. And that's not cliche. We mean this.
Yeah.
We want it to be the best. And so,
I'm sorry, go ahead.
No, go ahead.
I'm saying at the end of the day, many of us here work or live in DeKalb.
Yeah.
Is this from experience, Fidel?
I don't know if the north part of the county is considered DeKalb, Fidel. You're living the good life up there now. Come on.
Yeah, that's right.
I think the biggest thing is not just the airway management and being able to start an IV and things like that. I want them to be able to do an actual assessment. That's where
Yes.
90% of everything fails.
Amen. Amen to that.
Yeah,
Can you recognize that we have these problems? Not, do you know their airways bad? Do you not know their
Yeah.
breathing? We drill that into them. But if you can't ask them, how long has it been going on? Where are you hurting? And understand what the next answer is. It doesn't matter if you can start an IV or put it in an airway or put them on a non-rebreather. If you don't understand what's going on
Right.
and how to get there to find out that information, because you could be called for
Mhm.
one thing, it's abdominal pain, and it turns out it's actually not really abdominal pain, it's actually new onset diabetes. And you totally didn't make
Right.
this connection. You never checked the blood sugar because you didn't even think about it.
Exactly. There
So
you go.
that's the connection, is I want them to learn that over, you have to be able to start an IV.
And I've worked in rural areas where I had first responders. God bless them too. You know, remember the old Georgia first responders program we used to have, but
oh yeah,
volunteers, that sort of thing. And I've rolled up on scenes where they'll say the patient's having difficulty in breathing. And yeah, they're in failure and they're sucking on a non-rebreather, or they're not really sucking on it. It's just blowing in their face because they need to be bagged. And I know every one of us has seen this where you've had to rip off a non-rebreather and get your BVM and lay the patient down and go to work.
CPAP.
CPAP, BVM, but the non-rebreather wasn't cutting it.
Mm-mm.
And that's what Paige is right. That is what we're trying to put out there.
I want clinicians versus an EMT.
I do too.
Same here.
That's said
a
it good.
far-fetched hard
That's a
answer,
show title
but
for next show right there.
I don't know if it'll
want
ever happen,
clinicians.
but I can try.
Yes, you
And I
can.
can teach them every clinician thing that I know.
You can. And you do. And you do good. I think we all do good. Fidel, you did great the past few days. Fidel's been challenged with the same challenges that we've been facing, the whole class. And I'm sure Bill Graveo was here. He would agree. Every class is unique.
Oh yeah.
Yeah.
And
well,
so
we greatly appreciate your passion.
Thank you.
Pat,
I learned my passion from you.
Oh no. Thanks, Mike.
I did. I could not have had a better partner when I came to DeKalb.
Oh,
Paige.
Thanks, Mike.
You're making
I
them
miss
fly.
those days.
Those were good days.
Oh. So moving on, I'll go with my pick of the week.
Okay.
It's actually the sign above me.
Yeah, I was trying to read it the whole show.
May is National Mental Health Awareness Month.
All right.
And behind me
Oh,
is sheet 4, the National Suicide Prevention Lifeline. So we all know that it's become a big hot topic here with fire and EMS and public safety in general, of increases in suicides and stuff like that. I've had somebody very close to me commit suicide, and it's very important to me that I get the word out that if you need to speak to somebody, please call that phone number or come find one of us if you're watching this video and you work for us. We will be gladly to speak with you.
thank you, Paige.
It's awesome. And that is something too, Paige, right? We just now started probably addressing it with EMT classes. It was a macho thing, before. We run these calls all the time, get over it, and it builds, though. It builds and builds and builds. And you got to learn how to, you need to learn how to talk about it. And we have to be able, as friends and other providers, we have to be able to recognize it when somebody is suffering.
Yeah,
That's the point.
My pick of the week is a little different. The National Registry, it's National EMS Instructors Organization, right? Is it NRE? Anyway,
NAMSEs.
National Association of EMS Instructors. Thank you.
Educators.
Educators. That's what I meant to say, educators. But they're having a conference out in Texas here in July. Me and Paige are going to try to go to it if we can. But I would like to challenge anybody out there in Georgia at these levels of organizations to put on something that's an educator conference and not a responder conference. We need to learn how to teach. I need that. I'm starving for that more than I mean, I teach every day. We all do. And I'm not a first line responder anymore. So I need skills that build in that. And I'm challenging anybody out there in Georgia to start working on a class to help us, a conference to help us with classroom management, with putting, presentation management, how to be better teachers. So I would like to see that coming around.
Absolutely.
Yeah.
There's no way around it. Like I took a course, it was a week long. This is how you do these. Go have fun.
Right.
And do I know these skills and understand how to explain these things? Absolutely. But do I know how to teach is another story, and teaching is an art.
Sure is.
And I don't think I have that down to where I think I need it to be.
Yeah,
and I would love to learn more things from other people.
I would too.
Yeah.
It's like this. I mean, and my son's 7 years old. 1 + 1 is 2. And I tell him this, they don't get it. So, you start showing them, okay, this one plus this one. That's what we need. Even though it's easy to us to understand that 1 + 1 is 2, I need other techniques to be able to teach someone who doesn't know that information. I need to be able to get inside their head. And so,
right.
Guys, I really enjoyed this week. It was a great show. I look forward to the next week.
Mm-hmm.
And I will see you guys tomorrow.
See you bright and early.
All right.
I got quizzes to write.
Yep. Quiz time's coming.
Have a good night.
Adele, thank you for being here. Pat, again, thank you for being here. Y'all have a great night.
Thank y'all. Take care.